Welcome back to the second part of our videos. So laboratory values and investigation, specifically in this video we'll focus on iron studies and liver function tests. So let's go. All right, so now we have got the iron studies and the liver function tests. All right, so we'll start with the liver function tests. All right, so we'll start with LFTs. So LFTs, also called liver function tests, we have got in the most profound things that you need to know. There are three classes under liver function test, and you have to be very specific when they ask you a question to say, can you tell us about the liver function tests? You have to be very specific. There are three things. Number one, there are these tests or results that can indicate liver injury or liver cell injury. Okay. Number two, there are these tests that indicate for you what is called the synthetic function of the liver. Okay, synthetic function of the liver. That's your second part. All right. Now, the third part is the indicative of excretory function of the liver, because remember the liver has got a lot of functions. So now there are those that just indicate the excretory function of the liver. So now, what are those tests that indicate the liver injury or liver cell injury? They are further divided into two. You've got the liver cell injury and the biliary tree. Remember the biliary system, right? The right hepatic duct and the left hepatic duct joining to form what is called the common hepatic duct. And then after that, we've got what is called the common bile duct, which is the cystic duct joining the hepatic duct, forming the common bile duct. Now that duct, if there's injury to that, you've got specific, special kind of enzymes that we follow. Okay, that we follow. They are very, very specific and very, very important. Yeah. Now, the enzymes which we call liver enzymes are as follows. Number one, the aspartate aminotransferase. So aspartate aminotransferase is the first one, and the normal is up to 40. Okay, 40 international units per liter. That's your AST. And then alanine aminotransferase. Okay, alanine aminotransferase ALT is also less than 40. Okay, these two they indicate liver cell injury. So if the liver is injured or the hepatocytes are injured, you're going to have elevated or raised AST and ALT. Very, very important. Okay, now we've got two specific ones for the indicators of biliary tree injury. So if the biliary tree is injured, specifically the duct cells, we have got the ducts, the cells under the ducts or along the ducts, we call them duct cells. So once they are injured, they produce these two enzymes that are special. Number one, gamma glutamyl transpeptidase, okay, also called GGT. Okay, so gamma glutamyl transpeptidase is very specific for what? For alcohol. So if they ask you to say which enzyme is raised in alcohol, it's GGT. Okay, so gamma glutamyl transpeptidase, specific for alcohol and also for biliary tree injury. So in the female it's up to, in the male it's up to 58, in the female it's up to 32. So you can memorize these values. Now we've got the second one under the biliary tree injury, which is called alkaline phosphatase. Alkaline phosphatase goes all the way up to 117. So if you've seen, it's the highest. All right. It's also specific indicates biliary tree injury. But the disadvantage of this is that it's not specific because there are other tissues that can produce it, like the placenta can produce it, the kidneys when they're injured can produce it, the prostate can produce it, and many other tissues of the body. So it's not so specific as compared to the GGT. All right, but these two they indicate biliary tract injury. So if they ask you to say what enzymes will indicate the biliary tree injury, you go for these two. Okay, now the second part of the liver function test is what is called the synthetic function. You want to identify how the liver is functioning by producing those proteins. So you will determine albumin. So albumin, the normal is 35 to 50 grams per liter. Others will say 3.5 to 5 milligrams per deciliter. It's one and the same thing, okay? It's one and the same thing. So now if your albumin is less than 35, then it means that your liver has not been working over a long time. So it is hyperalbuminemia, right? And it indicates that the liver has been malfunctioned. So if you want to do the tests for liver, if you say liver function test, it's not just about enzymes, no. Okay, you have to be very specific. So you tell them, say there is the indicators for liver injury, and then indicators for synthetic and excretory function of the liver. So synthetic, you've got albumin, which is 35 to 50. Okay, if it's more than that, it's okay. It means you've got a lot of protein. So if you have got the chronic liver disease, you're going to have reduced levels of albumin, and that's all right as well. So that indicates that you have got reduced albumin, and it indicates that you have got a malfunctional liver. Okay, so chronic liver disease or acute liver disease, you can have reduced albumin levels, especially in chronic liver disease. Now we have got the second part of the synthetic function of the liver, which is called international normalized ratio (INR). So INR, the normal is 1 to 1.3. Now this one we don't determine it directly; it's calculated. Okay, it's calculated by comparing the laboratory specific prothrombin time, depending on what the patient is, to a standardized prothrombin time. I'll teach you about this next when we start discussing the coagulation studies. So that's about the international normalized ratio. It's 1 to 1.3. It's very, very important. And it tells you how fast the patient can bleed. Okay? Can bleed if they were injured, or they can just bleed. So if the INR is increased, it tells you to say it will take a long period of time for the patient's blood to clot, and therefore they can bleed severely. Okay? Or they can bleed very fast. That's what it means. Okay? And it can also be used in monitoring of vitamin K antagonist. Okay? If you give what you call warfarin, you can use it to monitor the severity and the toxicity of warfarin, the INR. So in short, it's about telling you for how long blood it will take for blood to clot. So if it's raised, it will take a very, very long time for blood to clot, and therefore the patient is going to bleed a lot. Because remember, clotting is protective for the patient. And it tells you to say the liver, which produces most of the coagulating proteins. Okay, most of the coagulating proteins are produced by the liver, except a few, and one of them it should be 8. 8 is not produced by the liver. Maybe it is, but not just to a lesser extent, or to a lesser extent rather. Now, so it tells you to say the liver is not producing what those clotting proteins over a long period of time. That's why it indicates the synthetic function of the liver. And then we've got the last one, which is the excretory function of the liver. So if you want to identify the excretory function of the liver, you determine what is called bilirubin. Okay, and the normal is less than 17. Also, you can say less than 1. So 1 and 17, they are just one and the same. So 1 milligram per deciliter is equivalent to 17 micromole per liter. Okay, so you can use either units, but others you usually use the milligrams per deciliter. So bilirubin will talk about the conjugated and unconjugated. We'll talk about all those in details. This is just a summary of everything. Okay, so you can take a deep breath. So that's the end of liver function test. Now let's talk about the iron studies. Okay, iron studies. So for iron studies, there are 4 parameters that are involved. Number 1, you've got iron itself. Number 2, you've got total iron binding capacity. Number 3, you've got ferritin. And number 4, you've got transferrin. Okay. Now, the first one is iron itself. The normal iron is 13 to 32. Okay, 13 to 32, that's the normal micromole per liter. Others we use micrograms per deciliter, and it's 5150. But the units that we usually use in our state or in our country, it's 13 to 32 micromole per liter. That's for iron. So if it is reduced, then you've got iron deficiency anemia. If it is increased, then you've got increased iron. Okay, and you do have to screen the patient for different conditions that can increase their iron. Okay, yeah. Now one of the conditions is what is called hemochromatosis. Okay, that can that can lead to increased iron levels in the blood. Okay, and then we've got the total iron binding capacity. So now this tells you to say how much iron is bound. That's what it tells you, right? That's what it tells you, the total iron binding capacity to those proteins. Which proteins like the albumin, okay, and the other proteins in the blood. So the total iron binding capacity is for the total 80. That's the normal micromole per liter, or 250 microgram per deciliter. Okay, that's the normal. Now, this TIBC can be raised or increased. The importance of this is seen in iron deficiency anemia. Okay, so in iron deficiency anemia, the TIBC increases. Why does it increase in iron deficiency anemia? It's very simple and straightforward. It is increased because the binding sites are left open. There is nothing there. Okay, so the total iron binding capacity is going to increase because you've got less iron. So less iron is going to raise your TIBC, and the reason why it's going to be raised is because the binding sites are not there. The iron that is supposed to bind to those sites of proteins, is not there. Okay, the iron is not there in the blood, in short. So if you reduce iron, and therefore you're going to have a raised TIBC. In short, it's the opposite, of course. It's just an inverse kind of relationship that is there between the TIBC and iron levels. So if we've got increased iron levels, you expect the TIBC to reduce because the binding site would have been occupied by those ions that are present in the blood, in short. So TIBC is for the 2 to 80, and you need to remember that I've explained the relationship between the iron and the TIBC. The other thing that is important is ferritin, okay? Ferritin is somewhat a storage form of iron, and it's also part of what is called acute phase reactant. It is produced by the liver, by the way, okay? So ferritin, the normal is 15 to 200. So in females, in the male it's 30 to 300. Just multiply 15 by 2, you get to 30, which is for male. Now, in the female, for you to say this patient has got iron deficiency anemia, one of the things that you look at that is very specific is ferritin, okay? So it should be less than 15. Okay, others will say less than 20. Then in the male should be less than 30, all right, or less than 20. Now, guys, this is very important, the ferritin. Except that it is an acute phase reactant, meaning that it can indicate if at all there is an inflammation that is ongoing. All right, it's an acute phase reactant, this one, but it can be affected by what? By the liver problems. So if the patient has got chronic liver disease, it can be forcibly elevated. You get the point. When the patient doesn't have when the patient has got iron deficiency anemia, it can give you a false positive to say everything is okay when the patient has what? When the patient has what? Has got chronic liver disease. So it's not also specific in such kind of instances, but it's very, very important to remember ferritin, okay? Very, very important. 15 to 200, 30 to 300 in the male. In the female, 15 to 200 in the male, 30 to 300 respectively. The last one that we are going to talk about is what is called transferrin. Okay, the last one we're going to talk about is transferrin. Okay, so now just remember that ferritin is the parameter of choice in diagnosing iron deficiency anemia. Okay, yeah. So you need to remember that. That's for ferritin. It's the most important, most profound one amongst the iron studies. So if you do your serum iron and you find that they are reduced, and then also the ferritin is also reduced, then it tells you to say the patient has got iron deficiency anemia. Because remember, ferritin is a storage form of iron. Okay, yeah, that's the storage form of iron that you have to really remember. The last one is, like I said, is transferrin. Okay, and we said the normal is what? Is 2.15 to 3.17 grams per deciliter, but in our setting we usually use the milligram per deciliter. So it's 215 to 375. Others will say 215 to 360. Okay, milligrams per deciliter. That's the normal value of what? Transferrin. Now, what's the purpose of transferrin? Transferrin is just a protein that transports what? Iron, okay, from one tissue to the other. Okay, that's what it does. So now, this one you can report it as the TIBC. It can be reported as TIBC. What do I mean? Because remember, it's like it's the carrying capacity of the ion. You get the point. Because it's the one that transports. So if it is reduced, it will tell you to say, if the transferrin is reduced, it tells you to say there's something that is ongoing. Okay, the protein is reduced, there's something that is ongoing. And then if it is raised, you need to know to say there's something that, okay. In short, what I said. So there's the same way you reported TIBs. That's how you report your transferrin. So if transferrin is elevated, it tells you to say you have got less protein, you have got less ions in your blood to bind to it. If it is reduced, then you've got more iron, isn't it? And if it's normal, then it's okay. Okay, that marks the end of this video. The other videos will come thereafter. We've got more videos about the other remaining lab tests or lab values that we have to know. Okay, so thank you very much. Just don't forget the deal. The deal is that you like, you share, you comment, and subscribe to this YouTube channel. Thank you very much, ladies and gentlemen. That was Dr. William M. Chansa. Until next time.